This week, we're talking about neurogenic shock. So this is going to probably be a little bit briefer. It's not something we see that common as an isolated shock. Good to be aware of, good to know of when we're just talking about the shock point of it. We're just going to have to close down on this. Sorry, real quick. You guys can just let me know if something comes up in the chat. I just wanted to close it out a little bit. So neurogenic shock, it occurs most likely secondary to a spinal cord injury. And what happens is that there's the initial shock or the primary injury, which is the damage itself to that area of the spinal canal, and then anything above that area. Then usually there's a secondary injury as well. The secondary injury can come, it's not that well understood. It can start to occur immediately, and then it can occur later on down the line, up to weeks after the initial injury. And this is multifactorial, usually comes from ischemia. So if you're damaging small blood vessels to that spinal cord, it can occur from that, or from a bigger ischemia, so loss of blood flow secondary to other trauma or injury, inflammation in and around the area of the spinal cord injury, any free radical formation. So when you have that injury, you're creating these reactive oxygen species, which go in and cause further damage to the spinal cord. And then maybe just some nerve excitability. So if in that area you're damaging certain motor neurons, they become hyperexcitable and they overfire, and that overfiring causes damage. Very distinguishing fact of neurogenic shock is what happens in it you have an injury to the sympathetic nervous system, and the parasympathetic nervous system is left unchecked. So the sympathetic nervous system is that fight or flight, and the parasympathetic is that rest and digest. So when you don't have that sympathetic drive, you have your secondary, you get a hypotension and bradycardia, because you don't have that secondary sympathetic nervous system that's causing your heart rate to go up as a response to the hypotension. So usually the distribution for that sympathetic nervous system arises from around T6, so the sixth thoracic vertebrae. So these injuries, in order for us to see a neurogenic shock or pure neurogenic shock, you're usually talking about an injury that occurs somewhere between the mid-thoracic spine and the higher cervical spine. Anything below that, it's typically not going to give you that pure neurogenic shock. And then we don't see it as much with isolated head injuries, because you can still have your sympathetic nervous system intact. So when you are evaluating these people, obviously it causes a pretty major traumatic incident to damage the spinal cord. So you want to remember that they're trauma patients and evaluate them as such. So you go through your traditional trauma assessment, your A, B, C, D, E, obviously all while maintaining inline mobilization of the spine. You can look peripherally to see if these patients are hypotensive. Do they have a concomitant bradycardia? You can look at their skin. Is it flushed or warm? They would probably have good peripheral pulses because they do have adequate vasculature. It's just that they don't have that sympathetic nervous system that allows them to have that vasoconstriction they need to shunt blood into the vital organs. So these patients will often have an airway issue, and a lot of times that arises because of the injury itself. So if you remember C3, 4, and 5, keep the patient alive. That's a English little chant or nomer, but your diaphragm is innervated by C3, C4, and C5. So if you knock out the higher cervical, then you're really at risk for having airway compromise, because you don't have the strength. You have no motor sensation. You don't have that strength to breathe. even if it's a little bit lower cervical, there can be some motor nerves that come up. So it's not just strictly in that area. You can have some motor nerves in C6 and C7 that go up and act with the innervation of the diaphragm. So even a lower cervical injury that has involvement of the spinal cord, these patients are probably going to need intubation, because even if they still have some of their diaphragm, there's at that point they're losing the surrounding musculature, like their abdomen and into their chest wall, that's allowing them to maintain their airway. And then you worry that they can't clear any secretions. So if they're lying flat, you're getting all of these imaging, you're keeping them in inline mobilization. They can't clear their secretions. They can't watch out for that airway. And so you want to have a pretty low threshold to intubate them. The other benefit for intubation in these patients is that you are ruling out hypoxia as being a contributor to a secondary injury to their spinal cord. So you're intubating them, you're giving them the oxygen they need, and that way you at least take one variable out of the picture, and you're doing your best to analyze you can in the long run. So for diagnosis and like as far as trauma patients, just to go back to that last point, make sure you're addressing their other injuries, make sure that you're addressing any loss of blood or any other immediate or life-threatening injuries aside from just their neurological injuries. So for diagnosis, as far as the spinal cord injury or cervical or thoracic injuries, so you can use a plain film. So there's some utility to that. It's pretty obsolete these days with how fast people can get to CT, how rapid CT is. But, if you, for some reason you needed it, you do have that available. But in any patient that has a concern for a true injury of their spinal cord, at the very least, they need an immediate CT without contrast of the cervical, thoracic, lumbar spine. And likely you're getting a CT of the head as well. If you have a patient that is relatively stable, or you have them intubated, they're on they don't have any obvious other injuries on CT, good idea to get an MRI as quickly as possible that can look at the spinal cord itself. And that's going to give you better assessment if there's any swelling or edema around the spinal cord, if there's any ischemia or hemorrhage or anything that is compressing the spinal cord that would change their immediate course of action. And then for neurosurgery, what their plan of action is going to be if there's any immediate procedures they can do to decompress the spinal cord in hopes that this injury doesn't become permanent to the patient. When you're doing imaging, another thing to consider, depending on the mechanism of injury, if somebody has a high speed motor vehicle where they have a hyperextension or a hyperflexion injury that has resulted in what you believe to be spinal cord injury, you should also consider doing a CT angiogram to assess their vertebral and carotid arteries, because if there's that much whiplash, there's a good chance that they could have severed one of those arteries. That would also change your immediate management. And by assessing these, you're limiting the risk of stroke later on. With labs, you're going to do similar labs to other types also want to try all your labs you can, so you can optimize, their electrolytes, their hemoglobin, their blood gases, just basically everything you can to make sure that you don't cause, or you can help stop this secondary injury. And then if you are getting ready, a lot of these patients do end up being surgical patients, so they do type and screens for them for preoperative stuff. So our treatment is often just making sure these people go where they need to be. And that's with neurosurgery. I mean, that's the underlying treatment. It's the best thing that you can do for these patients. But in the interim, while you're waiting for your neurosurgery consults, while you're making sure there's no other injuries, no other types of shock, there are some things that we can do. So definitely keeping inline mobilization of the spine. It's sometimes now the C-collar or backboarding, there's so much controversy, at least here, about it. But somebody that has a likely spinal cord injury is going to be aggressive with what you do. And these are the cases where I would keep that C-collar in place at all times. They don't have to be on a rigid backboard, but if they're being transported frequently, you're taking them to and from imaging, at least at some point they are going to be on a backboard. If the patient is intubated or you need to intubate the patient, consider, having somebody hold inline mobilization of the spine while you're doing the procedure. Try to use a glide scope because that's going to minimize how much you have to pull up their head. So in their jaw. So using that video laryngoscopy whenever possible in these patients. And, most of us in the emergency medicine world are very proficient at glide scope or video laryngoscopy to the point where you probably don't even need to take that C-collar off. So in these patients, that's beneficial. These are also patients where you should have your more experienced intubators do it because you want to minimize hypoxia. If somebody has a spinal cord injury and their intubation is prolonged or they have secondary hypoxia, that could potentially worsen their spinal cord injury or make it so that it's more likely to be permanent. So this is one where you get a more advanced, most advanced airway provider doing the intubation. During that intubation, you want to make sure that you're really pre-treating them, making sure they're not hypotensive. In this case, you can give, 1 or 2 liters of fluid just to kind of pump the vasculature. And you think about it, and we'll talk about this. So kind of going forward. So with the neurogenic shock, the goal is the neurosurgery likes to have these people with MAPS between 85 and 90. So that is higher than our tolerance for anybody with hemorrhagic shock or septic shock or cardiogenic shock. So in these patients, you want to see a higher MAP, and that's really to make sure that they're perfusing their spinal cord. And so that being said, you could just go with the fluids, but you can also use norepinephrine. And it's okay to use norepinephrine a little bit earlier in these patients, after 2 liters of fluid, because you think about what they need and they've lost their sympathetic tone. And so no matter how much fluid you give them, they're still going to be vasodilated. So their fluid is still going to be just coursing throughout, and it's going to have a harder time going to those vital organs because they can't constrict the vessels to get the fluid to go where it needs to go. So these patients are a good patient to start a low dose of norepinephrine. You can also use epinephrine on these patients because they have a bradycardia already. So they're bradycardic and you want a little pressure support. So in this case, epinephrine is an okay choice as well. But doing something, even if it's a small amount early, can help them, and that allows better perfusion to the vital organs, and it helps them constrict because they've lost that sympathetic tone and can't constrict their vessels on their own. If the bradycardia that you're seeing is pretty profound and you think that that's contributing to why their blood pressure just is not getting better, like I said, you can use epinephrine, but you can also use some atropine in these patients. And that's really, got to remember with atropine, it's pretty temporary. It has a very short half-life. So in somebody like this, they're not going to improve. Like, you can give one dose. It's not going to change the mechanism of why they're bradycardic, but you can be giving the atropine to increase the heart rate. And then ultimately, they need surgical stabilizations oftentimes. So this is neurosurgery, and you're getting your neurosurgery involved quickly. And that is the wrap up is pretty quick, like I said, because it's just, remember, a lot of times these patients are going to have other types of shock. It's not that common that you see an isolated neurogenic shock, because the mechanism of injury to damage the spinal cord is usually pretty great. So we'll move forward with the questions. So which of the following is the most common symptom in patients with spinal cord compression? Let's see. So yeah, I think I got an answer from almost everyone. So on this one, the answer is motor weakness. So when somebody has compressed their spinal cord, clinically, you can look at them, 60 to 85% of people with a spinal cord injury are going to complain of motor weakness at the time of presentation. And most often that is symmetrical. So that's just a kind of a statistical one, not much to know, except for just it's motor weakness is it's a very sensitive for having an injury to that spinal cord. So if somebody is telling you they have bilateral motor weakness after a trauma, have a high suspicion for involvement of the spinal cord. And on these patients, if they're not an obvious spinal cord patient, then think about getting MRIs to see what's going on with that spinal cord. And I'm going to tell you, then we'll read this, but I threw this in here because I am not good at these ones and I have to review them all the time. And I don't know if you guys use these same names in Vietnam, but here in the US, we get tested on these often. They come up on board exams, these certain types of cord syndrome. So it has to do with where the spinal cord is injured. And you guys may even have different names for them, which makes it even harder. But I put this in here because we get tested on them a lot and they're really challenging. So a 45-year-old female with history of arthritis presents with weakness in her arms and hands after being involved in a motor vehicle crash in which her head hit the windshield. She is able to walk, but has a 3 out of 5 strength in her bilateral upper extremities. Which of the following is the most likely diagnosis? So this is somebody that has their upper extremities are weak, but their lower extremities are doing okay. They have strength in their lower extremities. Shirley, you better answer this one. You got boards coming up. Okay, I'm going to give you the answer. This one is a central cord syndrome. And like I said, these ones get me so often. I have to review them all the time. But central cord is usually caused by hyperextension. So like this person hit their windshield, so hyperextension. And the ligamentum flavum is pushed into the spinal cord because of a distribution of the nerve fibers. The upper extremity weakness is more profound than lower extremity. The complete cord compression, that's kind of what the neurogenic shock, what we were talking about, is going to be loss of motor and sensory function at the level of the injury and below, so everything. The anterior cord syndrome also caused, so this one's by hyperflexion, and this one will cause paralysis, loss of pain and temperature, but preserved vibration and position sensation below below the injury. So anterior cord, just remember you have temperature and pain gone, but you can have vibration and you can still feel where you are. Brown-Sequard syndrome, usually due to penetration. So think about these with like your stab wound patients, cause ipsilateral, so same-sided loss of motor function, and then loss of position, and contralateral loss of pain and temperature. So really tricky. If you remember how the nerve fibers work and you do that, that is amazing. I try to kind of think about the actual injury to help me with these. And I put them in here as just a review for us all because they're really hard. And then spinal shock is a little different from neurogenic shock. And, that we didn't talk about as much because it can be hard to distinguish. But spinal shock, if you have an injury to the spinal, like an injury to the spinal canal or spinal cord or some of the vertebrae where you lose all motor, all sensory level, but it comes back. So it only lasts a couple of hours. So we're not talking about a complete disruption of the sympathetic nervous system that would give you the neurogenic shock. This is more your body kind of going into shock because of the initial trauma, but then being able to recover from it. So even in the immediate, spinal shock is very difficult to differentiate from neurogenic shock. And we're more worried about treating the neurogenic shock, even though we kind of treat these the same, because the neurogenic shock is going to be more permanent and we can help with that. So next one, 35-year-old male with no past medical history presents via EMS after falling from a tree. Patient is in a seat collar and on a backboard. His vital signs are as follows: blood pressure of 85/50, heart rate of 55, respiratory rate of 18, pulse ox 92% on room air, afebrile. His airway is patent. He had bilateral breath sounds. Peripheral pulses are all bounding in extremities. No open wounds or exsanguination. FAST is negative. Patient is alert and oriented, answering questions appropriately. He has numerous bruises and abrasions. He has complete loss of sensation and motor function below the level of T4. Which of the most is the most important step in treating this patient? So A, administer 1 liter of normal saline and reassess blood pressure. B, give atropine. C, obtain CT of the cervical, thoracic, and lumbar spine. Or D, obtain MRI of the cervical, thoracic, and lumbar spine. Good, I think most of you guys answered. So this one is A. So this patient is hypotensive. So his blood pressure is 85/50. So when you're initially evaluating him, you want to make sure you try to improve his blood pressure. So you're going to start with 1 liter of normal saline and then reassess his blood pressure, see what it does, see if he needs additional fluids, if you need to put him on pressors. But yep, I think most of you guys got this. The atropine is a consideration in him because he is bradycardic, but I think with that heart rate of 55, I probably wouldn't treat immediately with atropine. I'd probably just give the normal saline first, see what he does, especially because he has no other medical problems and he's pretty young. So it's even hard to tell in this guy if that is, that could be his resting heart rate at this point. Probably isn't, but I would give the normal saline first and then reassess that blood pressure. So I used the same question. And I actually tell you, I had a hard time finding questions on neurogenic shock. So I wrote this one. So the stem is the same guy that has this complete loss of sensation and motor function below the level of T4. So his presentation's the same, just with some additional information now. He was able to get CT imaging that revealed compression fracture of T4 with spinal cord compression. No internal injuries noted. After 1 liter of normal saline, the blood pressure remained 85/40. What should be done next to decrease the risk of a secondary injury to the spinal cord in this patient? Is it A, give prednisolone, B, get MRI imaging, C, administer norepinephrine, titrating the MAP to 85 to 90, or D, transfer to the ICU? Got our answers from everybody. Perfect. Yep, everybody got it. So administer norepinephrine, titrating that MAP to between 85 and 90 of pressure. So that's great. On a side note, I put in this methylprednisolone to talk about it. So they have tried this. Quite a few studies have tried this. I think people just want something to be able to give to help these patients that have an obvious spinal cord injury. So they've tried steroids in so many different ways with these spinal cord injury patients. They've tried giving them PO, IV, like directly into the area of the wound. And unfortunately, nothing has really shown any benefit. So giving steroids does not show any long-term benefit to these spinal cord patients. So at this point, there's no evidence to recommend giving it. If you're working with neurosurgery and they recommend giving it, I can't see really any major reason why not to, but there's just no proven benefit, unfortunately. And last one here. So 75-year-old female presents via EMS after a high-speed motor vehicle accident. Her family, who called ahead to the emergency department, said she had a past medical history of atrial fibrillation, for which she is on multiple medications. Her airway is patent. She has bilateral breath sounds. Peripheral pulses are intact. She has a GCS of 9. She has a seatbelt sign and bruising over her abdomen, and her FAST is positive. She has decreased motor function and sensation below the level of T10. Her vital signs are as follows: blood pressure of 65/40, heart rate of 75, respiratory rate of 18, pulse of 92% on 4 liters nasal cannula, and afebrile. What type of shock does this patient most likely have? Yeah, very good. Most of you guys got it. The answer is D, hemorrhagic shock. So this patient is hypotensive, which is shock. So we know she's in shock. If you look, she has got a positive FAST exam. So likely she has lost a significant amount of blood. You are much more likely to see hemorrhagic shock with trauma than you are a neurogenic shock. Her heart rate, yes, it's only 75. So would you expect somebody with that blood pressure in hemorrhagic shock to have a higher blood pressure or heart rate than that? Possibly. But in the stem of the question, it says that you were able to ascertain she has atrial fibrillation. So she's probably on a rate controlling medication for that atrial fibrillation. So remember, with elderly patients, you're often not going to see that rebound tachycardia with hypotension. So their blood pressure is going to be relatively low given the amount of hypotension because they're on medications that prevent that heart rate from spiking up. And so in this patient that has all these things, don't let it fool you that she's in just neurogenic shock. You got to make sure to look for those signs of blood loss, which she has. So she has a lot going on, but the one that's gonna kill her is gonna be that hemorrhagic shock. So you have to treat that with the blood products. Yep. And then somebody got it right on. Her heart rate is probably affected by her medications. And so I threw this one in there to just remind you, like when it's a trauma patient, we can see this neurogenic shock, but it's pretty rare because a lot of times these patients are going to have a lot of other injuries. And even, they have to have a full, complete loss of that sympathetic for them to have that bradycardia in addition. So even in patients with spinal cord injuries, it doesn't always lead to that bradycardia and the neurogenic shock. So, well, that is the last question I have. I would love to hear any questions, or if you guys have any good cases of neurogenic shock or anything really, please feel free. Do you guys have, does somebody tell me, do you guys all at every facility you work at, do you have neurosurgery?
Cái này ha.
What was that?
Can you explain more about why we maintain MAP 38, 35 to 80 millimicroC? Because
the blood.
Yeah.
No, go ahead. What were you going to say?
Blood pressure, mean blood pressure. Why to maintains blood pressure over 85?
Yeah, with the maps. So those recommendations came from some of the neurosurgery literature, and they recommend even more so than like a traditional shock patients where you're looking for MAP around 65. So they found that the patients did better when their MAPs were significantly higher. They didn't have any secondary, so preventing any type of secondary hypotension. So that way it was allowing better perfusion to the spinal canal as well as the brain. I think part of that, this way that I was reasoning with it, is because when we look for MAPs of 65 during other types of shock, these are to maintain pressure and perfusion to our vital organs, which typically are going to be our brain, our kidneys, our liver, our heart, our lungs. That does not often include our spinal canal. And so when your MAP is lower, when it's like 60 to 65, you don't guarantee that you're perfusing some of those more secondary organs. So by increasing the MAP, you are increasing perfusion, getting better blood flow to some of the less vital, quote unquote, organs, one of which being the spinal canal. So you're not just shunting blood to the vital organs, you're getting pressure and perfusion to all of the organs and all of the features, in this case, the spinal canal, preventing secondary injury to that area.
Yes, thanks very much. Yeah.
Mm-hmm. Does that make sense? That's what I, from what I saw in the
I understand it now. I understand now. Okay, thank you.
I have another question. Is there any rules of dexamethasone in
corticosteroid? When we use corticosteroid in spinal cord injury?
Yeah, I know. I think a lot of places will still use that, and a lot of neurosurgeons do still use that as commonplace, just giving it. But all the this data just unfortunately shows that it doesn't benefit. So it's not standard of care, just to be given from the ER standpoint. Like I said, if you have a neurosurgeon that's telling you to give it, I don't think there's anything wrong with it. And I don't know if there's been a lot of harm, so you can give it, but it doesn't show any long-term benefit. So for me, I've never given it unless, but if you're in the middle of nowhere, you don't have quick access to neurosurgery, there's nothing else you can do. It's one of those things where, you can try it and maybe it's going to help that one patient, even though it doesn't help in the studies.
Okay.
Yeah,
thank you.
It's hard to watch like a young person with a spinal cord injury and do nothing. So
yes. I want to ask you one small question. When we use atropine, the maximum dose of atropine is 3 milligrams, but in spinal cord injury situation, we can use more atropine than some maximum dose about average about 3 milligrams. Yes. Can you give your opinion?
I don't know on that one because it may be over the longevity. I don't think I would keep using atropine. I feel like if I was having to give atropine at that much, I might consider using epinephrine instead, especially if they're hypotensive, because that epinephrine is going to give them that sympathetic drive and should theoretically increase their heart rate a little bit as well. So then you would just be using one drug to do two things as opposed to just keeping dosing the atropine.
Yes. Thank you.
Mm-hmm.
In a situation you saw us about you saw of 35 years old male when the patient come emergency department with hypotension, but his heart rate is about 35. For me, if we use atropine immediately, I think it's very quickly to assess the patient more than you use 1 liter normoxanil. First question. The first or second question.
I agree. The heart rate in that one was 55.
Yeah. No. Box one question. Number one and number two. Okay. Sorry. It's number one. No. 35 years old male. Yes, that's right. Yeah. Why don't we use it give atropine? Because it's very quickly, just only 5 minutes. You can assess the patient.
Yeah, I definitely you easily could give atropine in this patient as well. Like with the heart rate of 55, you could give atropine and see if he responds to it, see if that does increase his blood pressure. Probably do both at the same time. I mean, this guy
thank you.
Who has both injuries, so it wouldn't be wrong to give both. I would personally probably just start with normal saline because it's there, it's easy, but giving the one dose of atropine is also appropriate.
Yeah,
because he is bradycardic technically.
Okay.
Yeah, I'd probably go to the atropine with more profound bradycardia personally. If he's got a heart rate in the 30s or 40s, like if he's low 40s, like low to mid 40s, I probably would. That's somebody I would consider starting just with the atropine if he's that bradycardic, rather than 55. And that's just, I guess, my practice. But I don't think you'd be wrong in this case to give atropine either.
Thank you.
Mm-hmm. Yeah.
It's very interesting election today because in Charai Hospital, many our college in Charai Hospital receive many trauma patients, but in UMC we don't have many patients with spinal cord injuries. So it's important for us to remember everything you saw us today. It's very nice subject today.
Oh, great! Thanks. I'm glad it was.
Dr. Dai, you share some case in Charai Hospital. because you receive the spinal cord injury every day.
Yeah. Yeah, I mean, these patients can be, it can be really scary when you see them. Like, I mean, a lot of times they're young patients. And so knowing what to do in the back of your brain, because they're the patients, when you see them, it's high stress because you feel it's tough. A lot of times it's multi-trauma injuries, but then they're younger, and you just know in the back of your head they have this life-changing injury. And so it can be hard cases to treat. For the physiology and the emotional side of things, they're tough. Well, if there's no other questions, I guess we will wrap it up. Anything else in the chat, or give it a second? I'll tell you too, the 35-year-old male patient, that was a patient of mine. He was actually an arborist. So he was cutting down trees and he fell out of the tree. And so that was actually my patient that I had. It was very sad. And he never regained any movement of his legs. Well, on that note, we'll wrap up. So next week is my last week, and it's anaphylactic shock. So anaphylactic shock will probably be another on the shorter side of lectures, because something we all see and kind of know what to do. I'll try to see if I can find some interesting information, but I want to hear some good cases of anaphylactic shock from everybody. If there's any concerns or questions after, you guys are always free to email me, or if you have a case come up on one of these things that you want to talk about, anything, please just email me. So it was great. Thank you guys so much.
Thank you.